and welcome to our next Unfiltered podcast or Unfiltered Productions podcast. It's been a minute, and it's so fun today. And those of you that listen to these podcasts, you're going to be happy to know that Cindy has a burr under her saddle. And that is a good thing when it comes to these podcasts because we often want to give her the opportunity to discuss what's going on. And the name of this one came to us as we were discussing what was getting her fired up, and the name of this one, But the Patient Lives Alone. Cindy, that is me coming to you with But the Patient Lives Alone. And so what is it that's on your mind?
Well, I think right now we're in an oasis lull. So whenever there's a big change, especially if there's a letter change, then we need education. We have to focus on education, and we want to make sure that the clinicians really understand the new information or the changed information. And there's almost a level of, I get a little excited because it's something different, right? But different tends to get attention. Well, we don't really have much that's different. E1 took away a couple questions, gave us only one new one, fixed a couple, and now we're in the period of waiting to see what the proposed rule might say. But even if it does make changes, those are a year out before they would go live. So what seems to happen in these lull periods is one of two things. Either we decide that we don't need OASIS education. OASIS is fine because there's nothing new. So everything, we don't need to worry about it or do anything with it. But as I told you, Sherry, if everything is fine, that would also mean you're not making any corrections or recommendations in the review process. I mean, actually, you're muted, Sherry.
I'm talking with my mute on. I'm so excited. I said that lull should mean that everybody's just improving on the OASIS data collection.
Right. I mean, it's information. We did education. It's now old news. It's nothing fancy. It should fall into just a cadence of we've got this. And yet there's still corrections going on. And overwhelmingly, they're about the functional assessment. And it's, yes, I know. But it's one of those, and it's, yes, I think about these things while I'm on vacation, is how many times are we going to keep talking about the same thing? And so when people reach out to K&K during these lulls, it's very often more related to I'm not happy with my star ratings, or I'm looking at VBP and I don't like how I did there. I think my staff need education. Yes, and maybe no. Because especially when we get into this functional assessment and the 2+ decades of my life now with, but the patient lives alone and they told me they can do it. Or, I think the time has come to really say, is education the solution or is it part of a bigger plan? Do I need to really start drilling down who needs education? Is it really my whole staff? Is it a particular discipline? Is it a subgroup of people? Because you don't want to haul a bunch of people in for education if they don't need it, which is why we keep advocating for our knowledge assessment / testing to be able to ferret out who's having a true knowledge gap. But sometimes I don't think it's a knowledge gap, Sherry. I think something else is going on. When clinicians, regardless of discipline, dig their heels in on but the patient lives alone, therefore they're independent, they're okay. But I think we need to order therapies, and then therapy gets in there and wants to see them a bunch. It's like what really is going on? It's more than just, let's look at the guidance again. Because if we keep looking at the guidance, it's the same guidance it's been for 20 years. There's different examples. They refresh the color scheme sometimes, but the fundamental, what you're supposed to be looking at for function, isn't any different. And I would love to see that section put to bed. I mean, except for new people. I mean, people new to home care, it's a different language, it's discipline neutral data collection. But the functional assessment, I think at times needs a bigger discussion than traditional education. Sitting down with clinicians and saying, okay, what is the roadblock? What is making you think that is the right answer? How do we peel that onion potentially and figure out what's driving it? Because sometimes I really just don't think, Sherry, that it's just a knowledge gap. And I think there's times where I provided education and my concern is that the target audience is kind of like been there, done that, heard that for the last 10 years of my life. But they still turn around and put in scores that either underrepresent the problem Or we get called in because clinicians are fighting the review process, saying, I'm not changing it to these other answers, but trying to figure out the why. I don't think it's just education. But that takes me in another direction because we have the lull. We tend to go back to the old habit, which we got to figure out how to break it. But then I think we get complacent on newer things in the Oasis because they're not function. I mean, things that are function have payment implications and all that. So we're always going to stay on that one. But my concern right now is the interview questions. And that's what I've just been calling them lately, Sherry, is the questions that literally say in the guidance, read this question, give them response options. If they're unable to respond for some questions, then you can use a proxy, which is someone designated by the patient. It is not me as the clinician. Or I can look at records. In other situations, even if the patient gives me an answer that I think is wrong, I'm perfectly fine. You have to put the answer they gave you. They're very scripted. We harped on that a lot during the conversion to Oasis E. But I'm beginning to wonder when we see clinicians doing an admission visit less than an hour in the home, when we see clinicians and I do, so much of my documentation outside of that visit, did they really ask the question? Because I can assess function, I can, take notes about the wound, and I can use my skills to choose responses later. But if I'm supposed to read exactly what's written, if I didn't, then I don't have an answer to the question. I can't just put down their race because I looked at them. I can't put down their race because it was on the medical record. Because if they identify differently and they could give me an answer, I'm supposed to use what they say. So what are your thoughts, Sherry? I mean, because it's like, I really wish, my big fantasy that I had recently was I wish EMRs would take every single interview question and put it like in one spot. Like, here's your script. Here's what you minimally have to do in the presence of the patient. These have to be. Because I think the way they're interspersed right now, I'm not sure they're getting asked. And our knowledge assessment results
that is a
confirm
great
that.
Cindy, that's a great tool that you just mentioned about putting it all in one document.
Mhm.
It creates a script for the clinician. I think that that's something that you can do very easily by copying and pasting from the PDF document that is the Oasis and have that set up for your clinicians as maybe a template from which they follow and answer those questions. I think that these situations are a little similar but opposite, right? So you have to interview based on the words that CMS gives you because they're trying to collect data on certain things. They want to know
Mhm.
how many people of color are in home health care at one given time, what their age is. They want to know everything about them demographically. And you have to ask those specifically because the research that they're gaining from this, it needs to be valid. It needs to be valid and based on what's going on with the patient and how they view themselves. That's very, very important. The other ones are the exact polar opposite of an interview question, but yet we know they're still being done as interview questions, and
Mhm.
we've seen it. Personally, I've seen it where we had an admitting nurse when I owned an agency that went out and said they were independent in bathing, and then when the therapist went out behind him, they said, "Well, show me how you get in and out of your bathtub," and there was a chest of drawers in their bathtub. So that's not independent. And so we need to make sure that two things, that we're not doing interviews on the functional questions, that we're actually seeing them get up and do these things and move around and do these things. And are they doing them safely? For crying out loud, can we just remember, yes, they're doing things they shouldn't be doing. If I got on a high wire, I shouldn't be there. If I wanted to do some backflips on a trampoline, I'm 59 years old. I should not be there. Okay. Doesn't mean I can't do it. Doesn't mean I can't get on a trampoline and attempt to flip. But is that the smartest thing for me to be doing? Is that the safe thing for me to be doing? So if we look at those functional items and we always bleed that safety in there, yes, they're toileting on their own. Yes, they're going in and they're getting a shower, but boy howdy, it's not safe. If you, I mean, you that am I thinking about this the right way, Cindy? In your
Well,
mind, you have to discern that.
but I think regardless of discipline, somewhere along the line, we've lost the ability to separate out someone does this on their own
Hmm?
and it's independent. Independent is me blessing it, saying that not only do you do it on your own, but I think it's a great idea. I
Right.
have no safety concerns. You could do it anytime, day or night. You were magnificent at it. So I'm putting my seal on this to say you're good. That is not the same as you do it on your own. Because there are things even our own family members do on their own. And you're like, oh, no, 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 no. It's not ideal.
But in a
I
big way,
wouldn't,
I'm going to interrupt you real quick on that
yep,
point. In a big way, we're shortchanging our seniors by over overwriting what they can do by saying that they're independent and something that they're not. Because if you think about it, think about the older folks in your life. Do you want them to have all the services they need? Yes or no? That's a fundamental question you have to ask yourself. Do you think those services should be limited or should they be wide open because you're out there every day seeing how disable or how much debility and fragility and frailty that it exists in these patients? So do you want to limit that care or do you want to expand that care? Because that's what we're trying, that's the data we're trying to collect, right? So
yeah.
we're trying to answer a question with CMS. So I'm
But
sorry.
I think sometimes, Sherry, the clinician interprets what you just said as, see, this is about money. So you're trying to tell me to pick answers so that the agency makes more money, maybe more money than they should. If you're watching K&K, you know anything about K&K. We die on the hill of accuracy. This is not a gaming institution whatsoever. It's just been fascinating to me that what we choose to do instead is downplay their problem, provide the care, and then get upset that Medicare doesn't pay us more.
Right.
Well, why are they going to pay you more if you said this really wasn't that big of an issue? But I think with function, Sherry, the safety has always been the problem. And then we see the development of, resources that I think clinicians say, oh, great. So now I got to take them in the bathroom and I got to take them over here. And especially as a nurse, I got to deal with the wound and I got to hook up an IV. I do not have time to do this entire tour of the house. And oh, wait, if I do it in these steps, then I'll get the right answers. I think there's value in your journey with Oasis to have a more defined process around where you take them. But I think over time, one of the biggest tells for me about are they safe is what does it take to get them weighed? We know that the Oasis says you have to get a weight. You cannot take a self-report. That is not a self-report question. If only it could be. But it needs to be a weight you take at that visit. And so I try to tell clinicians, let's just put the 1800s and the GGs aside. So when you go out to do an admission and you have to weigh somebody, what does it take? Because if that person was completely safe and able from a functional perspective, they could get up from wherever they were seated, or if they were lying down, get up out the bed. They would go to wherever the scale's kept. You wouldn't even be worried. You'd stay in the living room. You're not concerned. They go off to get themselves. They get on the scale. They'd read the number. They'd come back to where you are, give you the number, sit back down, and you wouldn't be concerned about that process at all. And yet, what happens more often than not? Oh my gosh, let me go get the scale. I don't even want to see how far back we got to go. Or I brought a scale and I'm going to put it right here. And then the patient's going to get up. Where are we? Well, we're not sitting in the other chair. We're there. Kind of an instinctive, I want to see how this goes. And then they get up and we go to the scale as quickly as we can. They get on the scale. Many of them have a walker or a cane. We ask them to let go of it as briefly as we can get away with to get a number. Clutch back on that and get back to the chair. That right there needs to be ringing the safety bells.
Yes.
Because if you or I had to go get a weight, we'd just get up, walk to the scale, come back. No, we wouldn't report the number on the podcast, but we could do all of those steps without being concerned. The fact we hover is an indicator of a safety concern. And I say hover on purpose because I think a lot of times when you have to put hands on somebody, you know there's a problem. If I have to boost you, lift you, put your shirt on, take your shirt off, I'm an active participant. I know you need help. But the 1800s in particular say help is also verbal cue and supervision. And I think a lot of times we hover as a precaution with our patients and we don't recognize that qualifies as assistance. So I try to get away from, let's make another elaborate multi-step tour of the house to get it and start thinking, I have to weigh you anyway. If my radar's popping just doing that, Then you tell me, oh, I can shower and whoa, wait a minute, slippery, wet, naked, getting in and out the tub. Okay. And you couldn't, with your clothes on, get on and off the scale without giving me a little palpitation. Yeah, I'm no, because back to your point, I think that the problem we've always had with interview is patients aren't truthful about function.
Right.
They tend to be, I have this wound, please look at it. I got to have this IV, please take care of me. I don't want to mess up my meds because that could kill me. But how I take care of myself can be a very personal, I don't really want to tell you that. Or concern that if I start saying, especially if I live alone, I'm having trouble getting dressed, I'm a little scared getting in and out of the shower. If I tell you that, are you going to make me go to a nursing home? Are you going to call my family member in another state and tell them that I'm having these? And then they're going to be all up in my business. So there's a bit of a motivation to downplay the problem. So yes, interview is part of it. And the questions do talk about information from a caregiver and this, that, and the other. But interview alone can be misleading. But I think if we just look at that task of weight, and how many times I see Sherry when I do OASIS audits, unable to take the weight. Really? Because you got them bathing and dressing and doing rolling and doing all this other stuff, but they couldn't get up long enough to successfully get on and off a scale.
And
That
so,
disconnect doesn't work for me.
but I also think that we need to add in there that there are evidence-based tools that we can use that are super quick to tell whether or not a patient is a fall risk beyond the MAC. It's gone. It just went away.
Back 10.
Thank you. The MAC 10, along with the MAC 10, which is a macro indicator if they have the risks of falling, and it's been studied. It's valid. It's not our favorite as therapists for sure, but it definitely has been through the rigors of education. But we have the timed up and go. We have gait velocity. We have the Berg balance score. We have the sit to stand test. We have a million very quick evidence-based tests that will tell you whether or not your patient is in a fall risk or not. And if they are a fall risk, how can they be safe and independent?
Well, and I look at it and say the OASIS doesn't even ask you why there's a safety concern.
Mhm.
That's where those tests and measures can really come in to figure out what is it. Because it is not, contrary to what you might be reading in some of the documentation, always a weakness issue.
Mhm.
I mean, balance comes into play, cognition comes into play,
Endurance.
fear can complicate this. The environment itself. I mean, if you go in there and not just the chest of drawers issue, but I've gone in there and the transfer bench, which we know is supposed to be over the side, is completely in the tub.
Mhm.
And the patient's telling me how awkward it was to use because she had just that little bit of space by the faucet. Okay, I showed her how to use it. But Oasis baseline for function is what they would have continued to do had you not come.
Right.
So I'm not going to leave her in this weird, unsafe situation. But what I did was an intervention. Baseline was her trying to shower with that whole thing in there, which is ragingly unsafe. There's no way I would want her doing that.
You have to.
So it is, I think the other part though, Sherry, is baseline is baseline.
Right.
And I think sometimes, especially on therapy Oasis events, is we see something, we say something, we fix it, which we absolutely should do. That's our job. But then we choose answers after we altered the environment, after we fixed the walker, after I took the transfer bench out. And now you've lost the opportunity to show the value of what you did. Now it reads that they were fine, and had you not come today, that it remained fine when that's not really what happened. You did something and changed it, which again, I always have to call this out, Sherry, because I've had people say, Cindy Kraft says don't do any interventions on the admission visit. That is not what I'm saying. I'm just saying you have to be cognizant of how was their function, and if you change something, make sure you're recording actual baseline.
Yeah, and remember, you're a reporter, right? You're going in there to make a picture, to write a picture through the Oasis questions of what that patient actually looks like in their home. And it's super important that you do that accurately and always with in the thought in the back of your mind, this person is afraid I'm going to take them out of their house. Because a lot of times patients don't want you at the house because they don't want you to see what they've been doing. and they
Mhm.
don't want to risk somebody being notified and coming and grabbing them out of their house and taking them to a facility. That is literally a baseline fear that they have, and you see it when you walk in and they start answering questions. Oh, I'm good, I'm good, I'm good.
Well,
We're
if you're not sure, Sherry, all you ever have to say is medical social worker, because
exactly,
they believe that the social worker drives the paddy wagon to the nursing home.
exactly.
Nobody says, "Can I please have a social worker?" It's like deer in the headlights. It's
Yeah.
like, no, we're trying to get you resources to keep you here. They don't necessarily see it that way.
No, they do not. And so it's your job to build that rapport so that you can make sure that they understand that you're going to have to back it up. Whatever it is says that you're doing, you're going to have to show me at some level, i.e., a standardized test and measure or something along those lines. That's not doesn't take a lot of time to determine whether or not they're a fall risk. Doesn't take a lot of time. But I want you to talk real quick in this last few minutes because we're at like 19 minutes, and we like to keep these around 20ish, what the risk is of some other things that we're seeing where people are walking and talking, but you'd think they were on the slab ready for the corner.
I think we have to be careful with how we're providing feedback about the functional assessment because there is the guidance, and then there can be some creative interpretations of said guidance to try to make the answers worse than the patient really is. And so, whoever is providing feedback, whether it's internal to the agency or a third party, you always have to check it against the official guidance and the most recent Q&As. I've seen things that are, well, CMS said you can. No, they didn't. The first part of that example is from a Q&A, but somebody kind of altered the wording of the rest of it, and it's clear it's trying to make you pick different answers. And so I think what can happen to clinicians is that if that happens once, that they were given feedback that they feel was motivated to make patients look worse than they actually are, sometimes all it takes is once. Now they don't trust any of the
Right.
recommendations. Now, even valid ones that say, no, that's not, they're in dressing, they're not a one, they're actually a two. If they felt at any point that somebody's tried to make them look worse, some of our folks, that's why I said it may not be education, it may be a conversation. If that's happened to them, maybe in the agency they were at prior to you, or they have a history of that, they may be the ones that are just refusing to make the change. And that's not an educational issue. That's a candid conversation
Mhm.
about we want, we are committed to the guidance. Let's look at the guidance together. I'm not telling you to put that answer so we make more money or any of those things you might be feeling, because I've seen clinicians where that's the thing. They felt somebody told them the wrong stuff and now they just don't trust it. And they don't want their name on a document where it's been gamed.
No,
And I can respect that. I would rather see that than the blind faith, our clinicians agree with every change we ever make.
really?
They should push back once in a while so we can have a conversation. But I think it's important organizationally to have that candid conversation because that could be what's causing, but the patient lives alone and I'm not going to put that. And what's my liability is not necessarily a lack of education. It could be a feeling of I'm protecting my license
Mhm.
because I feel that you're misleading or someone has misled me or tried to mislead me in the past. And now, traditional education, I'm just doing this because I don't trust you. And that can be fixed, but the conversation has to be had.
Yeah, and speaking to the clinicians now, because that's speaking to the agency, Cindy, and that is absolutely golden advice. But speaking to the clinician, it is perfectly okay to question a change to your documentation, but don't do it in a obstinate way. Do not be open to learning something new. And by learning something new, ask for the reg. Ask for where it is in the manual. The manual is the Bible for Oasis, and there are Q&As that happen that can be brought up very easily. Follow K and K. We send the Q&As out every time for the quarterly. So it's super important that you get that edification, that you understand and seek to understand why that change was made. If
Mhm.
they cannot provide you that regulation, if they cannot provide you that guidance in black and white ink on a computer screen in your hands, whatever, That's a whole other conversation. So, Cindy, what would you suggest someone to do in that situation? Or should we
Well,
just,
I get those questions periodically. I've looked everywhere and I cannot find the regulation that says, well, sometimes that dead end means there isn't a regulation
exactly.
that actually says that. And so whether it's OASIS guidance, as you just said, OASIS guidance or conditions of participation, or anybody starts with CMS says, or sometimes I get, but Cindy Kraft said, let's check. Let's look at the source because there's nothing wrong with wanting the source material. Because OASIS is discipline neutral data collection. It is not a clinical document. It is not a therapy thing or a nurse thing. So it does feel weird sometimes what it tells you to do, but those are the instructions we need to follow and make peace with. Um, just it is what it is, but there's nothing wrong with asking for source documents. And like you said, Sherry, being open to, okay, maybe I'm misunderstanding something. What are we trying to do here for our patient? Because at the end of the day, that is what we want to do, is be able to accurately report, defined by OASIS accurate,
Mhm.
what's actually going on in the home.
And take care of people. That's it. Take
Yes.
care of people, identify what their needs are, and do the best that you can to keep them in their home, which is our ultimate goal anyway. Cindy, thank you so much for ranting on our unfiltered production. If you have any questions about how to join Club Oasis and join Cindy on the regular about Oasis topics, just reply to this email and you'll contact us and we'll get you set up. Um, any other thoughts, Cindy, before we go?
Oh, I always have other thoughts, but we're out of time. We'll have to do some more of these again.
All right, everybody, hey, keep doing what you're doing out there and be safe.
Take care.